Good day, and welcome to Epstein Becker Green's webinar, The Challenging Crosswalk Between USPSTF Recommendations and Coverage Considerations for Payers and Providers. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program by using the Q&A feature provided by WebEx. If we do not address your questions during the webinar, we will reach out to you following the webinar to ensure your questions are answered. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have 2 fantastic speakers today from Epstein Becker Green. Lynn Shapiro-Snyder is a senior member of the firm in the healthcare and life sciences and litigation practices in the firm's Washington, D.C. office. Additionally, she is founder and president of the Women's Business Leaders Foundation. You can learn more about the Women's Business Leaders Foundation on www.wbl.org. And Lesley Yeung is a senior associate in the healthcare and life sciences practice in the firm's Washington, D.C. office. Before attending law school, she spent several years at the Center for Medicare and Medicaid Services in the offices of legislation addressing issues under Medicare Parts A, B, C, and D. At this time, I'd like to turn the webinar over to Lynn Shapiro-Snyder.
Hello, everyone, and thank you for joining this webinar. We were looking to see who were the attendees and noticed a very eclectic group. We're very pleased to see organizations that are from payers, organizations that are providers. We also see some life science companies on the list and several trade associations at both the state and the federal level. So thank you all for being interested in the task force. We are, Lesley and I are fascinated by what the task force's role is in health benefits and have dealt with several issues about the clumsiness in which their issuances convert into covered benefits. So we thought it would be a great topic to present and to educate so that other people can learn from the experiences we have. First, we're going to do an overview of what are the considerations for both payers and providers, because this is an issue that affects both parties. And then we're going to go back in time and walk through what is the task force, how did it start, how does it operate, and what is this preventive service recommendation mechanism that the task force is doing. Then we're going to explain how the task force, through the Affordable Care Act and some other federal legislation, got swept into the coverage rules for certain health care benefits plans, wanting to use 2 case studies that we thought would be of interest to this audience. And then as we said, on the Q's and A's, we have enough information to fill the whole hour. We're hoping you will send the questions in the email. Our facilitator, Whitney Krebs, is going to be monitoring for questions, and Lesley and I will either address the answers to your questions as we go, or we will be happy to reach out to you after the webinar to make sure all the questions are answered. And before we go to the next page, I just wanted to mention, although we are focusing here on the task force, there are other preventive services that are relevant to any benefits package, one being the Advisory Committee on Immunization Practices that comes out of CDC. Another one is the guidelines supported by HRSA, the Health Resources and Services Administration. But for purposes of today's presentation, we're going to do a very deep dive on the USPSTF. So let's have an overview. Why are we talking about this here? Well, first and foremost, group health plans and payers, and we're going to go into more detail like who are the payers that this applies to, because it does include the insured, the self-funded employers, are embracing coverage for preventive services, but there are requirements that are mandated under the Affordable Care Act where it is actually a requirement. That's what mandate means. So we're going to be answering some of the questions. What are the private payer rules for coverage of preventive services, including when the task force gives these services what is called an A or a B rating? And we're going to go into more detail about that. And then you're going to see how the recommendations are really speaking to the clinician as a practice guideline of what the recommendations are saying, and that does not always speak in terms of insurance coverage language as to scope of coverage, frequency, who the provider is. Consequently, the private payers struggle very often with translating these recommendations into coverage policies as to their frequency, the method, the treatment, who gets to provide the service, and the setting for it. So that's what we're going to look at. And just so you know, the requirements are more on the private plans, the plans sold in the exchange, a small group individuals, and there's a crosswalk to Medicaid plans. There are different requirements for Medicare, traditional Medicaid, and it does not apply to grandfathered plans. So what is the must? Okay, so first of all, health plans must monitor, because you never know when the task force is going to come up with their recommendation. So hopefully, usually it's in the medical director shop that is monitoring for this, but they monitor for these recommendations. There is somewhat of a cycle to the task force activities, but you never know when the recommendations are going to be published. They're usually published like in the Annals of Internal Medicine, that type of thing. Then you have to understand when there's a recommendation, how it must be translated. And the good news for the payer community is that the effective date is starting on or after the date that's 1 year after the effective date of the recommendation. And why do they do that? The idea is this is a new benefit and that payers already have their premiums filed with the insurance commissioners. They already have agreements with groups as to what the premiums are. So the goal was to try and give the actuaries and the health plans a chance to take it into account when they're pricing their products, and that it shouldn't happen the first day after a recommendation comes out, but that there is this annual cycle within the health plan life that this comes across. So the hope is that plans have an opportunity to incorporate it into their evidence of coverage, incorporate it into their price. So there are places where there is discretion for the health plans to determine the scope and who the providers are. We're going to look at that. And then one of the things that Lesley and I worry about when we're doing this work on behalf of health plans has to do with how do the health plans justify, either in a memo to the file or something, that they believe what they are doing is good faith compliance with the task force recommendations. And then sometimes we are advising on the provider side whether the providers could qualify as the right provider for satisfying the health plan's obligations on these new benefits. And so you'll see that one of the things we recommend, it'll come up several times in the PowerPoint, memo to the file documenting that the recommendation, how everyone evaluated the evidence, and you're going to hear about the application of what is called reasonable medical management techniques, because that's one of the things that is not as always understood is the discretion that plans still have, notwithstanding the terms of the recommendation. So consideration for providers. Providers need to understand that these are mandated covered items, but perhaps you are currently a primary care physician. How much can a primary physician do in this space? Could an extender, like a nurse practitioner or a physician assistant help? Could a registered nurse be someone to do this? But there are also less traditional providers in the community, such as community centers and health and wellness and coaches, because some of the things that we're going to be talking about are in the preventive space, not in the traditional medical surgical space, where once you're already sick, you're going to a licensed health professional. And not everyone who provides preventive services necessarily is licensed under state law. And sometimes health plans, they just want to embrace people who are licensed, but you don't always have to have a license to be a participating provider. So before we get to the next page, I did want to just mention that the task force, just because there are some people who may not even know what the task force mission is. So the U.S. Preventive Services Task Force, and this is a quote that you'll see in all these guidelines, they make recommendations about preventive care services for patients without recognized signs or symptoms of the target condition, end quote. So that's, first of all, it's an asymptomatic population. The next part of the quote, the task force bases its recommendations on a systematic review of the evidence of the benefits and the harms and an assessment of the net benefit of the service, end quote. So they're balancing, based on evidence, anything published, is it good to do the intervention or not good? And if the good outweighs the bad, it becomes a recommendation. The question is, how good is good? And the third part is that the task force, and this is a quote, recognizes that clinical or policy decisions involve more considerations than the body of evidence alone. Clinicians and policymakers should understand the evidence, but individualized decision-making to the specific patient or situation, end quote. And what that means is that when you're dealing with an individual patient, it's like the practice of medicine. You need to make your own judgment calls of what service is medically necessary and needs to be rendered. So with that in mind, there are two case studies that we're going to be discussing today. One is in the tobacco cessation counseling and intervention, and the second is in obesity, overweight, intensive behavioral counseling. And we thought before we get into the background, just to give you a sense of what we're talking about here, on the tobacco cessation, it began with planned years beginning on or after September 23rd, 2010. We're going to go into more detail of what are the required covered services. It actually ended up being defined in a Department of Labor frequently asked question, and we'll talk about that because that was unusual. And then who are the eligible providers, and you'll see it'll say things like primary care clinician staff, health system-based tobacco coordinators, or something called community resources. And as you see, those are the kinds of things that are what the plans struggle with. On the obesity, overweight, intensive behavioral counseling, there's one for obesity only, June 26, 2013. And then there's a more recent one, which I think is one of the reasons why more and more people are now talking about the task force. That one began August, it's going to begin on or after August 26th of this year. So a lot of plans and providers are talking about that now. It has to do with being overweight and having a cardiovascular risk. The required services, there's some flexibility to define the scope of coverage. There's some language in the task force recommendation, and Lesley's going to drill down on that. And then there are eligible providers, some flexibility of identifying who they are, including, again, you see that word community-based or non-traditional providers, such as what you're going to hear a phrase called the DPP providers coming out of the Center for Disease Control. So that's an overview of what we're about to do, and Lesley Yeung is going to take us through the background so that you all know about this very unusual entity called the USPSTF. Lesley, tell us a little bit about the creation and organizational structure and what their authority is.
Thanks, Lynn. Yes, as Lynn mentioned, we really have become interested in what the task force is and what it does, especially as coverage requirements have become tied to the to the recommendations made by the task force. So I'm going to try to provide a really pretty quick overview of what the task force is. There's a lot of information in the next few slides. I won't speak to all of it, but I wanted you to have the benefit of the information in case it's something that you're also interested in and want to look into engaging more closely with the task force. So on slide 11, the task force was created in 1984 as a government advisor that issues non-binding recommendations on preventive health measures. And the task force is an independent entity, but it is supported by the government, by the Agency for Healthcare Research and Quality, or AHRQ. From 2012 to 2014, the task force received about $7 million in funding from AHRQ through the Prevention and Public Health Fund. This was created by the Affordable Care Act. And in 2015, AHRQ didn't receive any funding from this fund to support the task force, but instead used other money from the Prevention and Care Management Research portfolio, which AHRQ has said it will use going forward to support the task force. I am noting this because, interestingly, in the recent House Appropriations Committee vote on the HHS budget for 2016, that budget proposal includes an elimination of all funding for AHRQ. So the budget hasn't been put into law yet. It still needs to be approved by the full House and the Senate. But the question is, if the agency were to be eliminated, which government agency would take over to support the work of the task force going forward? So we're going to move to slide 12, and I'm going to talk more about what exactly the task force does. Lynn talked about what the mission of the task force is, and that the recommendations are made to primary care providers about clinical preventive services that they should be implementing in their practice. The task force goes through a rigorous process of reviewing the evidence for a selected clinical preventive service and developing a recommendation statement based on the task force's evaluation of the evidence. And for a new topic, this whole process, it generally takes about 2 to 3 years to complete a final recommendation, from when they first start developing a research plan through to the end of the final publication of the recommendation. On slide 13, we're going to look more closely at who is on the task force. So the task force is made up of 16 members who are experts and leaders in primary care prevention, the evaluation of research, and implementation of evidence-based recommendations in clinical practice. The director of AHRQ appoints new members each year to serve 4-year terms. And the goal is to have a balance in the expertise of members on the task force. And the medical experts generally include a mix of different specialists, internists, pediatricians, family physicians, OBGYNs, nurses, and health behavior specialists. The members of the task force are volunteers, and there is an annual nomination process if anybody is interested. Individuals can self-nominate, or they can be nominated by another person or entity. Moving on to slide 14, let's talk a little bit about the recommendations themselves and how the task force assigns ratings to a preventive service. So as we already discussed, A and B rated preventive services are subject to specific coverage requirements in both the government and commercial market. But the task force doesn't hand out only A and B ratings. There's actually a spectrum of ratings from A to D, as well as I ratings. The USPSTF assigns a rating based on its review of the evidence and its determination of what the net benefit of providing the preventive service will be. When the task force assigns an A or B rating to a recommendation, that means the task force has determined that the evidence shows that the net benefit of the service is substantial or at least moderate. For C ratings, the service may be offered to certain patients because there is some evidence that there's at least a small net benefit to offering the service in certain circumstances, but just not to the general public at large. And then for D ratings, the task force recommends that the service not be offered because either there may be no benefit to the service or the harms of providing the service may outweigh the benefits. And Also, an I rating means there's insufficient evidence to assess the balance of benefits and harms related to providing the service. And so any service that has a CD or I rating is not required to be covered under the new preventive service coverage rules. So we'll be talking in more detail today about an A rating recommendation for tobacco cessation interventions, as well as two B rated recommendations for intensive behavioral counseling for adults who are overweight or obese with additional cardiovascular disease risks, and for screening and behavioral interventions for adults who are obese. But I wanted to provide you with a few additional examples of recommendations for some of the other ratings. Because, for example, a preventive service topic may actually have different ratings within it when you look more closely at the recommendation, depending on certain clinical or patient-specific factors. One example of this would be the recommendation for screening, genetic counseling, and BRCA testing. This is a B recommendation for women who have a family history associated with increased risk for breast cancer, but a D recommendation for women with no such family history. So a recommendation not to provide that service. Another example related to what we'll be discussing today is behavioral counseling for healthful diet and physical activity for adults without any CVD risk factors. So no known diagnosis of hypertension, diabetes, hyperlipidemia, or cardiovascular disease. Providing such counseling for purposes of cardiovascular disease prevention is a C recommendation, meaning that the task force doesn't recommend providing the counseling to all adult patients, but a clinician may choose to selectively counsel a patient if certain conditions exist in the absence of a CVD risk factor. Finally, an example of a service with an I rating relates to tobacco cessation. The 2009 recommendation that we'll be discussing is actually currently under review by the task force, and the task force recently published a draft recommendation that is consistent with the 2009 recommendation, but it also looks at evidence on electronic nicotine delivery systems, or ENDS. And the task force in that draft recommendation found insufficient evidence for use of ENDS for tobacco cessation, and therefore has given that particular piece of the overall tobacco cessation recommendation an I rating. But the A ratings still remain in place for the other pieces, which we'll discuss later. Moving on to slide 15. There are certain levels of certainty that the task force associates with evidence that's available on particular preventive services. If the task force has a high level of certainty on a topic, that means the evidence is strong and unlikely to change. A moderate level of uncertainty means that evidence exists, but there may be limitations to the evidence, or additional evidence could potentially change the task force's conclusion about the preventive service. There could also be a low level of certainty, meaning that the available evidence is insufficient to assess the effects of the preventive service on health outcomes. Moving on to slide 16, this slide discusses the process for recommending topics to the task force for review. The task force generally selects 1 to 2 new topics a year to evaluate the evidence and develop a recommendation statement. The task force also reconsiders after 5 years, depending on whether new research has been published or there's otherwise been a change in that topic area that warrants further consideration. On slide 17, we discussed the criteria for nominating a new topic. For example, the topic must be a preventive service relevant to primary care that addresses a disease with a substantial health burden. And this slide also shows how topics are prioritized for review. We're going to move on to slide 18. This provides an overview of the process for developing a recommendation. So the task force must develop a research plan, systematically review the evidence, and then draft and finalize a recommendation statement. AHRQ currently funds 13 evidence-based practice centers to assist the task force in the work that they do to develop the recommendations. And these, the they're called EPCs, are mostly universities or entities that are affiliated with the university, but they also include other private entities such as RAND or Kaiser Permanente and the Mayo Clinic. All draft documents are posted online for public comment, including the draft research plan, the draft evidence review, and the draft recommendation statement. And interestingly, just to give you sort of a sense of magnitude, on the USPSTF website, the task force identifies 6 topics that are in the research plan development phase, for the first phase, 27 topics undergoing evidence review, 7 topics in the draft recommendation phase, and 5 topics for which recommendations are now being finalized. And so with that overview, I'll now turn it back to Lynn.
So where we are now on the presentation, I'm going to take us to page 20, the intersection of the task force recommendations with coverage. Before I do that, I'm just going to pause for 2 minutes and answer some of the questions that have come in. For some of you arrived later, so it is recorded. You will get the slides 2 to 3 days from now. I just want to make sure we're getting, for those of you who did not hear the introduction. Number 2, a question came up on the Affordable Care Act. Does it allow payers to deny the coverage for an AB-rated service on the basis that the plan believes there is insufficient evidence? And the answer is no. It is a requirement. Once the task force makes the recommendation, it is a required benefit. There are a couple other questions that we'll be able to address later, but I just wanted to take advantage of that moment. So first of all, the U.S. Task Force began really as an advisory, non-binding recommendation, and that's when things get a little scary, is once you create something in Washington, D.C., it has a tendency to grow. In 2008, as part of the MIPA legislation, the Medicare fee-for-service program started to look at the coverage of individual preventive services for national coverage determination process and would use the task force recommendations to influence its decision-making on coverage. The real fundamental change came in Section 2713 of the Public Health Service Act, and then as added by Section 1001 of the Affordable Care Act, which requires group health plans, both insured and self-funded, and health insurance issuers offering group or individual insurance coverage, not only to provide this coverage, just pause there, so it's a coverage requirement, but also not to impose any cost-sharing requirements such as copayment, coinsurance, or deductible for what is called evidence-based items or services that have in effect the A and B rating in the current recommendations of the task force. So there are 2 pieces to the requirement. One is the requirement that it be in the benefits package, and the second requirement that there not impose cost sharing. Now, there are some plans that it doesn't apply to, so we're going to go a little bit deeper because I know there have been some providers and some consumer groups that get upset when their plans do charge a copay or are not offering these benefits, and not every health plan is obligated. It's most health plans, I would say at this stage of health reform implementation, it would be the exception, not the general rule on the private pay side, but there is a legal analysis that first has to be done whether these requirements do apply to the particular health plan that you're looking at. So we gave you on this page 21 the 2 main definitions. Those of us who work in the health reform space are very familiar with these terms, but we know on the provider side, and a lot of providers are listening on the phone, they may not be terms that you're familiar with. First is the group health plan. This is the employee welfare benefit plan established or maintained by an employer, or it could be by a union, excuse me, to the extent the plan provides medical care This could be an employer-sponsored group health plan, like we have at Epstein, Becker, an employer-sponsored plan, a self-insured plan where there is a third-party administrator, but the employer is the one insuring the benefits. It could be a self-insured medical reimbursement plan as well. And then the second is what's a health insurance issuer, and that's the actual insurance company where the insurance company is at risk. They are usually definitely regulated at a minimum of state law, and they could be either more managed indemnity or it could be health maintenance organization, and they're licensed to do business in a state subject to state laws. And those are usually, the health insurance industry usually has, generally speaking, three main buckets. The large groups, which could be 100 or more, the small groups under 100, and by the way, a group is 2 or more, or the individual insurance plans. Okay, so this is just a snapshot because we wanted the audience to have an appreciation that there currently are 55 preventive services with the AB rating. We just happened to choose 2 of them that we wanted to highlight. One is more mature than the other because we do believe that you need to follow all of these in terms of how the guidelines are worded, what happens after the guidelines are issued, how the health plans decide who are the providers providing these. And a lot of these services are predominantly going to be delivered by, more likely than not, a primary care physician, but not exclusively, or an extender. But more and more of these preventive services are using community-based organizations as a legitimate participating provider for the provision of these services, and we wanted to make sure that you understood this was an Epstein-Becker kind of created chart. It's not that easy to maneuver all the stuff that's on the task force website. Okay, so let's go through it one more time. So it's the who, the when, and the what. Who, it's private payer coverage, so it's offered through the group health plans or the insurers, must include preventive service AB, we just did that. They have to add it, and again, I'm going to repeat the time period. It's the first plan year, policy year beginning 1 year after the effective date. So some of the complaints we hear on the provider side, they say they're not doing it yet, and the answer is they don't have to do it yet. You have to wait until the new policy on or after because there is an effective date window that is pretty long before health plans have to do this. And then the bigger issue, in my view, is the what, which are private payers have some flexibility in how they determine the scope. The federal regulations talk about expressly the requirement that they pay with no cost sharing, does not prevent them from using, and this is a phrase called reasonable medical management techniques in order to control the cost. Where we are today, this deals with frequency, method, treatment. In fact, it may be that they do want to embrace some of the community-based providers because those with licenses or higher are going to be perhaps more expensive to provide the kinds of counseling services that are now included. They are not merely a referral for a service, although years ago the recommendations were merely for a referral. Now the actual preventive service is the counseling itself, and I know Lesley's going to speak to that a little later, and I have counseling even in my tobacco example. But I do want to just pause for a second. In health reform implementation, there is pricing pressure on our health plans to make the most out of every premium dollar, because anytime there's an increase greater than a certain percent, there are different filing requirements and even some states that are pushing back on the ability of the payer to increase the premiums year to year. In return, the payers and the providers have to get smarter on what's an efficient benefit. There's all different criteria for efficiency. And what's good about the task force recommendations is that if the evidence is there and there's flexibility, and this is something that will make the benefits package more efficient, there is no reason why people are not embracing this on a going forward basis. The issue really comes down to there may be a difference of opinion regarding the who that delivers the service or the magnitude of the service itself. But I wanted to mention the National Association of Insurance Commissioners did come up with model language for preventive services for the health plans, but all that does is give you that 100,000-foot language about AB rating, blah, 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 but it doesn't go into the, like, and what are we covering really and who's going to provide the service in the weeds. On the next page, you're going to see we added 2 other comments here. There have been some controversies around what's in-network and out-of-network, and nothing precludes the plan or the issuer that has a network of providers from imposing cost-sharing requirements for the covered service if you're an out-of-network provider. And so that's one of those other controversies that people say they're not in compliance, but the plan really is in compliance, but the provider is out-of-network. You know, the devil is in the details. And then the last piece we want to mention is coverage for treatment. And this is where there's sometimes a miscommunication or misunderstanding of the 4 corners of what is a recommendation. And if the preventive service discovers you have cancer, then the plan may impose cost-sharing requirements on the cancer treatment, even though the treatment emanated from the preventive service. It doesn't mean that all of a sudden all the services that flow from the preventive service are with no cost sharing. And you would think that you shouldn't have to say that, but you have to say that in order to make sure everybody knows what is and is not covered. On the next page, how the task force reviews the evidence and recommendations. The evidence and recommendations are conducted and written for primary care providers, so providers may revise and incorporate them. The recommendations generally are not written in the context of payer coverage. I want to pause for a second. Somebody had a question about the role of specialists, physicians, and there is an issue about the role of specialists, and there's also, to some extent, depending on what the preventive service is focusing on, who the provider may be. I urge those who are from specialty organizations to become involved in the task force. It's a public opportunity for you to review and comment, and I don't know off the top of my head who they've chosen to be on the task force and what the criteria is for that, but if that's something that some of the specialty organizations may or may not want to sit on the task force, I just know that from a group decision-making standpoint, it helps to be in the room. So we're about to give you some examples and some case studies. So let's move on to the case studies. Lesley, help us be introduced to our 2 case studies.
Thanks, Lynn. So now that we know, as Lynn described, that there's a requirement to act when a preventive service is recommended by the task force with an A or B rating, we wanted to look more closely at a couple of examples to talk about what some of the issues might be as we translate those recommendation statements into coverage policy. So the first recommendation that Lynn will discuss is related to tobacco cessation. And for adults and pregnant women, the task force recommends asking about tobacco use and providing tobacco cessation interventions or counseling. And then the second set of recommendations that I will discuss in more detail are related to obesity and overweight behavioral counseling interventions. So Lynn, why don't you tell us a little bit more about the tobacco cessation recommendation, and then I will talk about obesity and overweight.
Okay, so how would you like to look at a summary of a recommendation? So we scanned it in. By the way, this is being recorded. You will get the recording and the slides I know people keep asking about that. So you will get both the recording and the slides. I'm so happy people are interested in this topic because we love this topic, and we hadn't seen too much out there in the world. We have clients that were very interested in this topic, and thank you for your interest here. Okay, so tobacco. This is what it looks like. This is a summary of this is the A rating. There is a B rating one, which we're not going to talk about today, about education and brief counseling for school-age children and adolescents. This is, I want to just pause and have you look at, this is for adults greater than 18 and pregnant women. It tells you what the counseling is. It tells you about the pharmacotherapy. It tells you about the implementation, and it has recommendation on the bottom. This was something that was published in the Annals of Internal Medicine. I'm going to go through a little bit of a cron. So let's go to the next page. Before we get to May 2014, I thought I would just tell you how it all built up to get this frequently asked question. It goes back to the year 2000. Public Health Service has a guideline. Then it was reviewed by the task force in 2003. Then the Public Health Service revised and came up with a revised new evidence treating tobacco use and dependence, a 2008 update. Then the task force picks it up and says, we found convincing evidence that smoking cessation decreases the risk of heart disease, stroke, and lung disease. Then the Affordable Care Act comes along, makes AB services a requirement. And lo and behold, these types of services now need to be in those specific health plan products without cost sharing. All right, so you say, what should the health plans cover? And it's not 100% clear, because when you read the guidelines, and you have to go into the footnotes, you have to figure it out, and so lo and behold, the next thing we know, there are different stakeholders who are complaining that they don't understand what the guidelines are, leading up to what is there are different booklets and things on the internet, and lo and behold, we get to this bubbling up to this frequently asked question coming out of the triumvirate over health reform. Just so you know that under health reform, 3 federal agencies are what I call the Federal Department of Health Insurance. One is the Cessation, which is in the Department of Health and Human Service, Department of Labor because of ERISA, and Department of Treasury because of the tax deductibility of employee health benefits, and we have an FAQ. It talks first about insurance generally. There's a FAQ right before this one, but now we have more guidance. So what does question 5 actually say? It says, since there is a task force recommendation that clinicians ask all adults about tobacco use and provide tobacco cessation intervention for those who use tobacco products, what are plans and issuers expected to provide as a preventive coverage for tobacco cessation interventions? And then you see they talk about for those who use the tobacco, it became translated into 2 tobacco cessation attempts per year. And then when covering attempts include 4 tobacco cessation counseling sessions for at least 10 minutes each. They can be by telephone, group, or individual without any prior authorizations. And they're supposed to cover all the FDA-approved tobacco cessation medications, both prescription and OTC medications, for a 90-day regimen when prescribed by a healthcare provider, again, without prior authorization. So that's how the crosswalk worked. It took a while. We got the FAQ. Now what we have is this is under review again. The task force is currently updating the 2009 recommendation. It was open to public comment until June 1st, 2015. One of the things you're going to see in that is the whole issue of reviewing the evidence on electronic nicotine delivery systems and whether those should now be included as part of whether the evidence is still there. Right now, the task force has said they still found insufficient evidence as to those particular products as to whether they were going to recommend or be for its effectiveness for tobacco cessation. So we just want to give you a sense of how that kind of worked. And then we wanted to also bring to light in March of 2015 this year, the American Lung Association, which has been very active in this space, issued a report examining state implementation of tobacco cessation coverage requirements. Now, they chose the qualified health plans that are offered through state-based and federally facilitated health insurance exchanges. Just so you know, in their report, they are able to document that a disproportionate amount of the population that historically has been uninsured is tobacco users. And then a disproportionate amount of the ones who got health insurance through the public exchanges, whether it's state-based or federally facilitated, are also disproportionately to the general population users of tobacco. So this is a real unique opportunity to really make a difference in people's longevity, et cetera, in order to embrace the tobacco cessation coverage. And what they did was they were looking through publicly available documents, looking at whether issuers of the health insurance products were providing coverage for all 7 of the tobacco cessation medications. They did find, they actually differentiated that the state-based exchange products were marginally higher in their compliance to the federal. But as you can see from the statistics, there's work to be done, whether in fact the health plans are providing the coverage but don't have it on their formularies. We don't know. That has to do with a claim-by-claim basis. But from a consumer outside looking into the health plan, we have information from the American Lung Association to suggest that the plans are not doing 100% compliance here. We see that the best category is on no prior authorization, but there's no transparency. We do know there have been activities at the state level, awareness, regulator bulletins, consumer alerts, but there's work to be done, and one of the ways to do that is through this PowerPoint presentation. Well, we want to go through the next case study, which is on obesity, overweight, behavioral counseling interventions. Lesley, take us through that recommendation, because that's also a more recent one than the tobacco cessation.
Thanks, Lynn. On slide 31, we've provided a side-by-side comparison of the 2 recommendations. One's related to obesity and one's related to overweight behavioral counseling interventions when there is a CVD risk, an additional CVD risk factor. So the obesity recommendation on the left-hand side of this chart came out in 2012. The recommendation is for clinicians to screen patients for obesity, and patients with a BMI of 30 or higher should be offered or referred to intensive multi-component behavioral interventions. We also provided a summary of a description of what those interventions typically include in the provided chart, and that's all information that we pulled from the USPSTF recommendation. And on the right-hand side, we talk about the 2014 recommendation, which is for overweight or obese patients who also have a cardiovascular disease risk factor. This recommendation is for intensive behavioral counseling interventions for patients who are overweight or obese with an additional CVD risk factor. And again, a description of what those interventions typically look like is included in the chart. Before we move on, and Lynn alluded to this earlier, I thought it was important to really note how the 2 statements here describing what the recommendations are alone bring up an issue. that can arise in translating the work of the task force into a coverage policy. So just by looking at this, you may be asking, okay, so what services are actually required to be covered here? Is it just screening for obesity? Is it just the referral to counseling services if the physician doesn't provide the counseling services directly? And there are different ways to look at this, but I think it is important to consider what the intent of the particular recommendation is, remembering that the recommendation wasn't written as a definition of coverage, but rather as a clinical guidance for clinicians. So what is the task force really trying to promote with the recommendation, and what is the recommended preventive service itself? I think it helps to look at the titles, actually, because the title of the 2012 recommendation is Screening for and Management of Obesity, and the title of the 2014 recommendation is Behavioral Counseling to Promote a Healthful Diet and Physical Activity for Cardiovascular Disease Prevention. Therefore, I would say that those are the preventive services that need to be provided, and then the payers have the flexibility to determine the scope of the services and how those services are delivered. So let's move on to slide 32. The recommendation statements for the preventive services that I outlined in the chart on the previous slide, they do not define a required format for the recommended intervention or state who must furnish the service to the patient, or even how many interventions or counseling sessions really need to be provided. And the task force points out in the 2014 recommendation that many configurations have been tested and are described in the literature, and there's no one configuration that has been proven to work best. And so the task force really just provides a range for how comprehensive and intense the services that have proven to be successful typically were, based on the evidence that's reviewed. And further, unlike the tobacco cessation recommendation, there is no DOL FAQ already in existence or in process providing guidance on how to translate these recommendations into coverage policies. Rather, payers have the flexibility to define coverage and really should spend the time looking at the language in the recommendation as guidance for how to determine what coverage should be. But if you think that additional guidance would be helpful, anyone can ask the DOL to publish an FAQ on the topic. So you should certainly reach out to DOL, and I think that's what happened with the tobacco cessation FAQ. Enough people asked for guidance on it that they published an FAQ. So moving on to slide 33, I'd like to take an even closer look at the 2014 recommendation so that we can focus more on various coverage considerations that a payer may face. There's particular information that can be culled from the task force recommendation statements on how to structure the preventive service benefit, but a medical director may want to go further and dig into the evidence itself. The task force does publish all of the evidence that it reviews, so it is available online for a payer to look at. There can be, I think in the 2014 recommendation, there are about 90 studies, so there's a lot of evidence to wade through. But the recommendation statement really does try to cull it all down and provide a summary of what the typical interventions look like. And so using the 2014 recommendation as an example, and it talks about intensive behavioral counseling interventions that focus on behavioral change. They include particular educational components such as audit and feedback, problem-solving skills, and individualized care plans. They generally had 5 to 16 contacts over 9 to 12 months, depending on the intensity. And this is what we were discussing before, is how the task force generally provides this range, but doesn't say that any particular number of contacts need to be provided. The services that were provided generally were in-person sessions with additional telephone contacts being made, and they were delivered by specially trained health professionals. The task force lists various we wanted to actually first take a step back and look at, based on the information that's in the task force recommendation, what can we determine? Who is eligible for the preventive service? And the recommendation statement says that a screening must be done for a patient, whether the patient's overweight or obese, and then secondly, whether the patient has an additional CVD risk factor. The task force lists various CVD risk factors, including hypertension, hyperlipidemia, and dyslipidemia, impaired fasting glucose or prediabetes, metabolic syndrome, obesity, diabetes, and tobacco use. And in thinking about that, I think an interesting question arises when looking at those CVD risk factors, because if a patient is obese, is that enough to qualify for the intensive behavioral counseling under the 2014 recommendation, since obesity is a common risk factor for CVD? And I think this does actually provide a really good example of how the 2014 recommendation builds off of the 2012 recommendation, and how the recommendations could also overlap with the tobacco cessation recommendation. So there's a few things to think about here. First of all, if a patient is obese, there's already a recommendation specific to obesity, and a patient who's determined to have a specific BMI should receive multi-component behavioral interventions as a result of the 2012 recommendation. But a patient who is obese and has an additional CVD risk factor, that patient would fall under this 2014 recommendation for intensive behavioral counseling services. However, there needs to be a consideration of what the appropriate types of services for that patient would be, because the multi-component behavioral interventions and intensive behavioral counseling services described in the two recommendations are similar, but there are some differences, and there could be some differences in intensity that a patient might need depending on what their condition is. Further, another thing to think about is if a patient whose CVD risk factor is tobacco use, then that patient should receive tobacco cessation interventions, either as part of or in addition to the intensive behavioral counseling related to healthful diet and activity under the 2014 recommendation and the prior 2009 recommendation for tobacco cessation. So that's a lot. We've got overlapping recommendations, and it's up to the payer to determine how to make the most efficient use of the premium dollar while covering all of the appropriate preventive services to the patient. And without further guidance, there's really a number of things a plan could think about doing. They could do nothing because it's all a little bit too confusing, but then they would not be in compliance with the coverage requirement. They could rely on services that they already provide, potentially around weight management or other counseling services, but it would really be up to the plan in those instances to look at what they're already providing and determine if that really meets the level of intensity of the services described in the recommendation statements from the task force. Or alternatively, some of those services, there may just be non-coverage for weight management services alone. And so the question would be, how is the plan going to come into compliance with the coverage requirement if they're solely relying on something that they already have in their plan? And then the third option would be for plans to look for options on how to provide the level of services described for these various recommendations, the multi-component behavioral interventions and the intensive behavioral counseling interventions, either using physician services or community-based services or other alternative provider types. So let's actually look at slide 34 now, because at least for the 2014 recommendation, the task force actually acknowledges that it's pretty difficult to take the descriptions of the interventions included in the clinical evidence and putting those into practice. Therefore, the task force provides two examples of how the 2014 recommendation could be put into practice. And these examples could be really helpful to payers as they look to establish coverage for programs that address the 2014 recommendation. Specifically, the task force identified the Diabetes Prevention Program, or DPP, and the Premier Intervention, which is based on the DASH diet. And the task force determined that these two programs address the preventive service recommendation and could be delivered in the primary care setting or by local community providers. So looking at the DPP program as an example, the CDC has actually established criteria for approval of a DPP provider, somebody who's offering a program in the community setting. And namely, these approved DPP providers must offer a curriculum that meets the duration, intensity, and reporting requirements described by the CDC in their Diabetes Prevention Recognition Program Standards. So as Lynn has described it before, this is sort of like a URAC accreditation for diabetes prevention programs that, for these programs that focus on providing intensive training and counseling and diet, physical activity, and behavior modification. So it's possible that the DPP program or the Premier intervention could serve as a good starting point in terms of how to define coverage. It may not touch absolutely everybody who's eligible, but at least it's a consideration that the task force made in the recommendation itself. So hopefully, maybe as a indication that they're starting to realize that their recommendations really are really do need to be translated into coverage policies. So with that, Lynn, I'll turn it back to you now to go through the overview again and the final wrap-up.
Okay. Before I do the final wrap-up, though, I want to go back. There are a couple of questions that have popped in just to make sure we're addressing what people are asking. One of the questions came up is, if these are guidelines, why are they required for providers? And I just want to make sure it's clear, our information, what we're talking about is if it's an AB-rated recommendation, it is required to be a covered benefit in these private health insurance plans. That does not necessarily translate into a requirement for a primary care physician to provide the service. That depends upon that particular participating providers' desire to provide preventive services generally as a practice guideline. And if they are participating providers in a health plan, that health plan may have recommendations that they're looking for, or it's within the scope of the services that you're providing. So I wanted to make sure it was clear that the requirement is in the benefits package side, not necessarily in the delivery side. So I don't know if that answered the question. If the person asking the question wants to have a conversation later, we could have a conversation later. But I want to make sure people understood that the actual requirement is on the health plan side for purposes of the task force. Other question, we did a little just on there are 16 members, medical experts, on the independent panel of the task force. When it was created, they had to be experts in what was called primary care prevention, including internists, pediatricians, family physicians, gynecologists, obstetricians, nurses, and health behavior specialists. We have a page in the PowerPoint talks about how each year the director of ARC appoints new members to serve 4-year terms. I think there as Lesley Yeung mentioned, there's some issues about whether ARC is going to still be alive and well as an agency in Department of Health and Human Services, but the task force goes back to the Public Health Service, which still is around and will be around. So the fact that the task force is mentioned in the Affordable Care Act suggests that if for some reason ARC is no longer an agency, some of the questions coming up are, it would probably go back to the Public Health Service, still be an HHS, still be around in order to facilitate what it does for a living, which is to come up with these practice guidelines, which are now codified in a federal statute to equate into a benefits package. So the mere fact that the Agency for Healthcare Research and Quality may or may not be around does not take away the fact that this is a requirement in the law, or it does not take away the fact that the task force is alive and well. One other question that came up had to do with the mental health parity law, which is a whole separate discussion, and we will, that person, if we will reach out to you at a later time to discuss the mental health parity. So let's go through near on the end of the presentation, because we want to go back. Several people have asked to just go back and explain for the two case studies that we were talking about during this presentation. We've gotten several questions again on the effective dates. How do these effective dates work? So we're on page 35, and I want to go through each one a little slowly so everybody gets it. So, for example, the recommendation that occurred under tobacco cessation, coverage, counseling, and interventions was in 2009. So as you can see, it starts with plan and policy years beginning on or after September 23rd, 2010. And then the same thing on the obesity and overweight intensive behavioral health. We had the two guidelines, one going back, which was only on the obesity plan years beginning on or after June 26, 2013, and now we have with the cardiovascular risk and overweight, it would be for plan and policy years beginning on or after August 26, 2015. I will tell you August 26, 2015, for a lot of health plans, they disproportionately start a plan year at certain times of the year. There's a whole chunk of the health plan business that uses January 1 as their effective date. There's another chunk that uses June or July 1 as another cutoff time period. There are some that are October 1, in which case that may be the first time we start to see the second guidance, the overweight and CVD risk, showing up in health plan benefits. But if I were to estimate, we probably won't see it until 2016 on the plan policies, evidence of coverage, or how the participating providers. So that's part of that whole issue of all of a sudden there's a guideline and then everybody thinks it should show up in the plan benefits, but there is this delay that occurs. And it's an opportunity for providers to become the participating providers for these unique kind of preventive service benefit. It's an opportunity for the health plans to put in their evidence of coverage these types of benefits and who would be the provider, because I think in some situations this could be a product differentiator for health plans in the marketplace. Okay, then on the required services, as Lesley mentioned, there was a Department of Labor frequently asked question on the tobacco cessation. We don't have the flexibility of that right now for the recommendations dealing with obesity or overweight. Whether something like that were to happen, it's possible if it turns out that there's a lot of differences in the marketplace or confusion in the marketplace. But in our view, there's enough language in those recommendations to really craft it. We found that if you compare the tobacco cessation one with the obesity and overweight guidelines, there seems to be a lot more information now on the part of the task force to share information about what they found in the evidence, and also going through the footnotes of what the studies were, there's a lot more information about what worked. So it should be easier, and this should be a ritual that health plans are now more able to embrace on how to capture this in a way that would be compliant. And finally, on the eligible providers in both categories, we have some interesting developments and changes going on traditional and non-traditional providers, not just in the preventive area, but we have in the whole issue of remoteness, telemedicine, telehealth. But I think that more and more health plans, who is a credentialed provider. I know, for example, whether it's in Medicaid managed care, Medicare Advantage, private health insurance, there's a lot going on about credentialing and making sure people are, quote, enrolled, that providers are enrolled in the health plan, trying to do perhaps more narrow networks in order to have a more efficient premium. But in these contexts, some of these preventive services can only be or more likely to be effective with some of the more non-traditional providers as opposed to the traditional providers. So I think people need to think outside the box when they come to these particular services as to who would be credentialed and how to even bill for some of these services, the more and more that these types of services are going to be covered services. So with that, we wanted to just pause for a second. And Lesley, I know, are there any other closing remarks that you would like to make at this time, Lesley?
No, and again, hopefully we went through all the case studies and tried to point out what some of the considerations are, and hopefully it's been at least helpful to point you into what the recommendations say and places to look for further guidance. But again, as Lynn had said, we're happy to follow up and talk more specifically if people have specific questions that we can answer.
Okay, so on the final page, I just want to wrap up. So what did we just accomplish? Because I want to make sure private payers and providers hopefully by now have an appreciation of the task force and how the recommendations for preventive services are implemented. The task force may rely on evidence considered under previous recommendations when developing new recommendations. Related recommendations have a tendency to build on each other, such as what we saw with tobacco cessation, obesity, and overweight intensive behavioral counseling. And those of you I see from the registration list who have or who do conduct research and are in the academic medical centers, et cetera, really are in a position to influence this. Private payers and providers should understand the mandatory coverage requirements. Remember, it's mandatory coverage related to the USPSTF recommendations with an AB rating. And then just so everybody knows, the trend is toward coverage of more preventive services rather than less. Preventive services going to the whole issue of accountable care and population health management. So this is a trend here to stay. And then we wanted private payers and providers to monitor these recommendations, including new and revised one. And if you are one of the stakeholders, to get more involved as a member of the public, understand how you can influence the recommendation process and to implement the coverage requirements, hopefully in a compliant manner for the benefit of everyone. With that, we are going to sign off on Whitney, close us down, and then if people have further questions, they're welcome to email either Lesley Yeung or myself, Lynn Snyder. Thank you again for the registration. We had a lot of people on this call from very different stakeholder parts of this issue, and hopefully we were constructive in getting the word out of what this is all about.
Thank you for joining us. This concludes today's webinar. If you have any questions, please feel free to contact today's speakers, Lynn Shapiro Snyder at lsnyder@ebglaw.com or Lesley Yeung at lyeung@ebglaw.com. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.